are with us. So I would hand over the request. Dr. Ramdeep Prasad Singh, the president, is on to welcome all of them, and then hand it over to Dr. Sami Swain for continuation of the program.
Good evening, everyone, the moderators, the teachers, students, and all participants on this evening program of BPH. We are call it bread and butter for the urologist, and it's extensive one. Aim is to make you proficient for examination as well as in your practical life. So be free to ask questions. Any doubts, clear it. And this is detailed discussion is going on every day. It's good program. Please all requested to participate, and we start. The moderator, please start the session.
Good evening, sir. Respected Ranveer sir, respected Ranjendra sir, and our faculties and students who have joined and learned for today's session. So it's a privilege to be a moderator in this session. So we have today we have a case discussion regarding LUPS and probably prostatic disease. So we should be very practical and it should be very clinical oriented. For that, we have expert with us, Dr. Bivas Ranjan Kundu, and teachers will be Dr. Anjan Das, Dr. Navneet Das, Dr. Rahul Gupta, Dr. Srinivas Narayan. So we have a plan to have a discussion of various cases with a brief lecture by the teachers. So we have students Dr. Tada Ajay Kumar, Dr. Kamal Kishan Das, Dr. Anik Bose, Dr. Anurag Misra. All the students have joined. Hello. Hello. Hello.
Sir, we can hear you. There was some background noise. We can hear you nicely.
We can hear you.
Yes, sir. Students have joined or not? I just wanted to confirm.
Yes, sir. I am
Name the
students.
Ajay, you are present?
Yes, sir.
Students.
Say yes, sir.
Okay.
Kamal,
So,
Kamal.
Yes, sir. Myself, Kamal Krishna Das. Good evening, our
okay,
teachers.
You are Kamal. Okay. Who else is here?
Sir,
Ajay.
I am Manik Ghosh.
Okay. Manik.
Sir, I am Manik Ghosh.
Okay.
Sir, I am
So, to start with, we have with us Dr. Bivas Kundu, sir. He will be giving some overview regarding evaluation and management options. So, Kundu, sir, over to you.
Okay, can I share screen? Can you hear me now?
Yes, sir. Please.
Can you share screen? I need to share the screen. Now, can you see the slides?
Yes,
Sir, we can see.
You can see the slides, can you?
Yes,
I can't tell the. Yes, Anjan, can you see the slides?
Yes, I can. Your voice is clear. I can see the slides. What is new in BPH in 200.
Right. So I'm going to kickstart this discussion on BPH this evening. Welcome everybody. students, colleagues, and senior colleagues. Dr. Ranbir, regards to you. Let's get on with
Thank you.
what is new and how we can get on with the management. It is based more clinically than actual. I always start a discussion on BPH with this slide. This is from a paper by Harry Har. He is a consultant and a very esteemed uro-oncologist at Sloan Kettering, New York. And very, very rightly said, over centuries, the prostate has been lanced, punctured, punched, cut, crushed, scarified, sliced, enucleated. We have done everything possible to do whatever we have to get this disease cured. And so it has plagued men since antiquity. So I can't get the slide to proceed now. Right. So if you look at the recent advances, there has been a lot of studies on lifestyle and medications. There are advances in surgical evolution and minimally invasive surgical techniques as well. We'll just touch upon a few, but the emphasis will be how I deal with the day-to-day PPH as in my clinical practice, and I suppose your exams are not different from that. So let us look at what has changed over the last few years. There is a lot of literature now relating the metabolic diseases, the obesity, and healthy living to prostatic diseases, and that has been linked, and a lot of specific nutrients contribute to link between diet and LUTs. This is a paper from India, from Indian Journal of Urology in 2014, which was one of the pioneers in suggesting that there's a consistent epidemiological evidence supporting a link between diet, physical activity, obesity, and LUTs. We now know that metabolic syndrome with glucose intolerance, insulin resistance, and obesity significantly reduces prostate volume. And the proposed mechanism is by increased estrogen and systemic inflammation. So men with diabetic glucose intolerance or diabetic range are at increased risks of LUTS. So that is as far as the epidemiological advances in the last few years. Let us look into the aspects of history complaints, investigations, trial of medication, and surgery. So these are the subheadings that we would like to discuss our subjects. So a common presentation is a typical BPH. We all know that a patient comes to your clinic with various degrees of obstruction and a mixture of LUTS. You know that the term prostatism, which we used to use in our student days, has now been replaced by lower urinary tract syndrome. There are symptoms of bladder outlet obstruction, and there are obstructed void and slow stream terminal dribbling. And there are symptoms of irritable bladder, which are mainly presented in the LUT syndrome. So a typical BPH is a mixture of all that, and we get this kind of a patient. But sometimes you're knocked out, especially in a hospital setting, where a patient presents primarily with urosepsis. And if you delve deep into the clinical aspects, you will see the central cause is an enlarged prostate, which has started off the whole process of the septic events. Renal failure and obstructive uropathy is another methods. Hematuria causes concern, and these are the patients that come early to you. You have to be very careful in evaluating a hematuria because they can masquerade a prostate. They can have other diseases along with it. So one has to be very careful in evaluating a hematuria. And of course, the acute urinary retention, which is the hallmark of obstruction. And if you have a acute urinary retention, it is the end stage of a bladder outlet obstruction. So these are the usual common presentation of a prostate patient. What do we do for investigations? A clinical history, of course, listen to the patient, but the must do tests are these three. Ultrasound of the KUB with the pre and post void, that will give you an idea of the bladder compliance, how much residual urine is there, how much the bladder wall is thickened, that will give you evidence of obstruction and for how long. Uroflow gives you a direct evidence of obstruction, and a PSA to screen patients to rule out clear-cut malignancy. So these are the must, absolute must. There was a recent discussion also on DRE. Some people argued that DRE is now extinct. It is not. In all the papers and all the randomized control trial, digital rectal examination has retained its place. One has to put a finger in the rectum and make sure that the gland, consistency of the gland, size, and other elements that you want to. Many times you'll find a residual bladder, palpable bladder, and a lot of other interesting findings that you can find out from a DRE. Role of urodynamics is limited to a few distinct quarters. You can do a urodynamic in most cases, but people don't because it's cumbersome, it is not easily available, and is an invasive test. So you define urodynamic in cases of incontinence or equivocal obstruction, where you have got a detrusor underactivity, which will show up on the uroflowmetry as an obstruction, but you know that the pressures are low. You have a suspicion that patient has a detrusor underactivity. Those are the cases where urodynamics helps in clinching diagnosis. So in any event where there is a equivocal sign of obstruction, it may be obstruction, it may not be, and especially in patients with incontinence, urodynamics is necessary to protect ourselves from medical legal issues and also to give a more correct diagnosis to the patient. IPSS score, again, is not widely used in India. There are score tables and we know the charts, but somehow it has gone into the in the domain of research and writings and papers. But in clinical practice, IPSS is not so much used. So trial of medications. How long do you use that? This is not defined. Even today, we do not know how long you can keep a patient on medications for prostatic obstruction. But you know when to stop if there is an onset of complication. If there's a very large residual which is building up on subsequent ultrasounds, hydronephrosis, stones, UTI, these are absolute indications to stop medical treatment and correct it surgically, because these are areas that can complicate and you can get organ damage. So prevent organ damage at any cost. So trial of medication, when to stop, is a very, very important pertinent question, because sometimes the treatment is not in the hands of urologists. Many physicians treat them and they do not know when to stop. So this is a message that you and I will have to carry to the other colleagues of other specialties. Surgical intervention, absolute indication remains the same as it was in the 70s. Stone, hematuria, infection, sepsis. If you have any one of these are almost absolute indications for surgery. How to intervene is a question that will bother you and bother everybody, but I suppose the surgical ease and availability is the answer. You have to relieve the obstruction, whatever is available within your gambit, that is the best thing to do. There is no test, no control trial that will tell you a laser is better than a TUR or a bipolar is better than a monopolar. If you are happy with instrument and you are using it predictably with a predictable result, that is the approach to use and relieve the patient from obstruction. So let's go through the list of medical managements of BPH. We know all the drugs. I'll not go into the details, but I'll just take salient features out of this chart to tell you what is happening in these areas in the recent times. Alpha blocker monotherapy, 5-alpha reductase, combination alpha blocker, tadalafil monotherapy, that is PDE5, combination tadalafil and finasteride, anti-myasthenic and a blocker, beta-3 agonist. In the alpha blocker monotherapy, silodosin is very popular, although most studies have shown that the ultimate effect of tamsulosin and silodosin are not much different. The choice of alpha blockers depends on many factors. Sexual dysfunction remains one of the major. We know that if the patient is young and sexually active and is concerned about sexual side effects, then you choose drugs like alfuzosin, which is supposed to give on the papers the minimum of ejaculatory dysfunction. The worst of them is silodosin. It's a very selective alpha blocker, but it gives you ejaculatory dysfunction up to 22%. But they are very short acting. Silodosin's usefulness is in two areas. It is cardiosafe because it's super selective alpha blocker, alpha 1A blocker to be precise. And it can be used in nocturia and trial without catheter. If you're using a drug for trial without catheter, you would select a drug which will act very fast and very shortly. Silodosin fulfills that criteria. Otherwise, there is no much difference between silodosin and tamsulosin in terms of efficacy after 2 or 3 weeks of therapy. One thing that one should remember that both silodosin and tamsulosin are selective alpha-1A receptor blockers. Both can cause ejaculatory dysfunction, but with different grades and degrees. Tamsulosin, as well as all other alpha blockers, causes floppy iris syndrome. So to be avoided if a patient is undergoing cataract surgery. And one thing that has to be borne in mind, if you are prescribing alpha blockers to a young patient, you have to be very selective on the choice of tablet. That's what I just said. In more than 90% cases, the ejaculatory volume is reduced. There is a 35% incidence of anejaculation with use of tamsulosin, and alfugestion use did not experience anejaculation. That is a paper published in 2006. It has not been refuted. There are papers to supplement this study, and by and large, we have followed this principle of using alfugestion for younger adults. Younger in the sense that they're sexually active. These are some newer developments just to tell you that what is happening in the field of research, transient receptor potential channel modulators. These are not meant for this evening's discussion, just to let you know that TRP channels are now identified as the irritant. These are the receptors which cause all the irritative symptoms of the bladder, the burning, the urge, pain, thermosensation, the broad chapter of dysuria. You would get in your private practice a large chunk of dysuric patients who are blurred as far as our treatment profile goes, because you will not be able to find out why they are having dysuria. Sometimes maybe at some stage we'll have these TRP inhibitors to give us answers to this huge areas of undiagnosed patient. A few words about 5-alpha reductase inhibitors, very useful drug. This is the only drug that will cause a substantive change in the volume of the prostate gland. You all know that. Finasteride and dutasteride, two brothers, but somehow dutasteride is a stronger brother. We somehow believe that dutasteride is a more powerful drug. It is not. After 3 or 4 months of therapy, the treatment effects are the same. The three myths that carries with 5-alpha reductase inhibitors are that it can cause breast cancer. It's a myth. It has now been proven wrong. Dutasteride causes heart failure. Combat trial suggested. A meta-analysis showed significant that no significant cardiovascular risk was detected with dutasteride. It was later proved by further ascites. And the most important that affects us is whether 5-ARIs causes high-grade prostate cancer. This has come from the study reduced trial, which showed that although the general incidence of cancer prostate is reduced, high-grade cancer prostate has gone up in the series that was published in the REDUCE and PCPT, the prostate cancer prevention trial, finasteride. That was way back. These are the two large pioneer trials. This prompted the FDA to advise prior evaluation of cancer prostate. On this subject, I'll tell you what has happened after that. But before I go on to the next slide, I want to tell you this, that many physicians prescribe dutasteride without knowing the PSA, and it is a dangerous practice. Once you prescribe a dutasteride to a patient and the patient has had it for a month or two, the PSA will go down and they will avoid detection. It will be very uphill task for a clinician to suspect and diagnose a cancer prostate after using dutasteride. So the rule that FDA has advised applies to Indian soil as well. We must have a baseline PSA done, an evaluation of the cancer prostate done before prescribing dual therapy, that is alpha blocker with dutasteride. But nowadays, people use it randomly. Even the first prescription would be a dual blocker, and that actually is a cause for concern. So this was highly debated. It was sub-analyzed why high-grade prostate cancer was found. It was later found and published that the alcohol made the difference. So it took many years to find this meta-analysis of 13,892 men, and they were not associated with increased risk of cancer. This was proven afterwards, and therefore dutasteride got a clean sheet, and the myth of causing high-grade cancer was abolished after this. This was the meta-analysis showing a study of 13,892 men. What happens to tadalafil? You know that tadalafil is a PDE5 blocker. This is the only drug in the PDE5 family which was recommended for use in BPH or blood outflow obstruction. The only drug which has stood the test in the FDA protocol is tadalafil 5 milligram daily. And this was a study published in the BJUI in 2014 for a 3 months period, which showed satisfactory treatment outcome using tadalafil over placebo. I looked into the data and find out what is happening to tadalafil chapter now into 2023. I picked up this paper and this was 2021, and this is a meta-analysis of 15 RCTs, and they confirmed that tadalafil 5OT was safe and potentially effective treatment.
Sir, need to make it faster.
Fast, okay.
So please.
Right. We'll just go through, right? Right. Okay. So these are the newer development in the fields of medical management. I'll just summarize the medical management in 2 lines and then go on to the new surgical treatments. I told you about all this. This is nothing new. Surgical evolution. Paying my regards to Peter Frere, Terence Millen, the pioneers of prostate surgery, Hugh Hampton Young, and open prostate, which has now been abandoned for the laser, and the thulium and the holmium laser has come in. Lot of discussion on resection versus enucleation, bipolar saline versus monopolar saline, and bipolar enucleation. The battle is still on. Whereas now the minimally invasive therapy has come up in a big way. The 5 contenders are Urolift, which is picking up in a big way in India, water jet aquablation, non-heated sterile saline, robot-assisted prostatectomy, water vapor thermal therapy, and embolization. And the papers are on, and aquablation and TURP have the necessary qualification. In another paper by Klaus Rebon, very powerful paper, it says aquablation, regime, and Urolift are minimally surgical options capable of providing rapid, significant, and durable relief for LUTs. This is another paper, very powerful paper by Chris Chappell and Peter Gilling, all the big names in the industry, and they also certify that prostate urethral lift is the only procedure with level 1 evidence and therefore can be recommended for treatment in men LUTs in the minimally invasive setting. I just wanted to mention these few options in the minimally invasive surgical treatment. And I will leave this special situation, just show you the slides of 4 special situations that you can discuss. I'll not go into the details for paucity of time. This is a situation 1. You have prepared a patient for surgery. It's a 90-gram prostate worked up for HOLEP. And on the day of operation at cystoscopy, this is the finding. What do you do next? Situation 2, another workup patient, planned TUR, all ultrasound uroflow confirmed, and this is the urethral state. What do you do for this case? Do you go and do it, explain the patient, or do it differently? A special situation 3 is on the day of planned surgery, you find that the patient is on dual antiplatelet. This is a very common setting and discovered on the morning of surgery. It has evaded all the various detections. What do you do next? Cancel and repost, counsel, take special consent, whatever. This is a subject of discussion. And special situation 4, the last one, is a patient presenting with this kind of a belly with a chronic detention. These are not easy problems. These are very difficult bladder to treat. They are decompensated bladder. And as you can see, they have bilateral hydronephrosis. What do you do next? Put a catheter, slow decompression or immediate decompression, operate urgently, or operate up to optimizing. These are the subjects that, and when will the catheter come out? What would you tell the patient? How long will the catheter be there as a pre-op diagnosis? So this is in short what I wanted to highlight on the BPH, and I welcome others to take up the platform and discuss this. Thanks. Amit, take over.
Yes, sir. Thank you, sir. It's a nice
Thank you, Dr. Kundu.
Hello.
Thank you, Dr. Kundu, for very extensive and elaborate discussion on the management of the BPH and especially also the recent advances related to it. With this, I would request Dr. Sami Swine to start with the case presentation and the students' participation as soon as possible.
Yes. So it's actually a nice overview and very conceptually how to approach a case of BPH. So coming to the first case, Dr. Anjan Das sir will be the teacher for this session, and any two students can be can participate.
Yes, sir.
Hello. Yes,
Hello.
you just introduce yourself, and Anjan Das will be continuing this session. Who else is there?
Sir, myself,
Yes,
Pawan
sir.
Krishna Das.
Yes, Anjan.
Myself,
Anjan Das.
Hello.
Sir, Dr. Anjan Das, sir, please take over, sir.
Hello, can you hear me?
Yes, sir.
Yes, sir.
Slide is visible. Please.
Students, please identify. Two students, please identify yourself.
Hello.
Sir, Dr. Ajay from IPGNR.
Okay.
Myself, Dr. Kamal from Fortis Hospital, Kolkata.
Okay. So I'm starting with a long case. Can you hear me, all of you?
Yes, sir.
Yes, sir.
Okay. This is a 67 years male, thin build, is a known hypertensive for 10 years. He had a history of LUTS for 3 years and 3 to 4 years. Presented with presented with retention of urine on Foley's catheter. He presented with me with retention of urine on Foley's catheter for 3 months. He has given a history of hematuria once, and he has also told that occasional urine leakage. So, Dr. Ajay, how
Yes,
will you proceed with the case? The
sir, I
67
want
years.
to. Sir, I would further ask patient in detail about LUTS, whether it was predominantly storage symptoms or mixed storage and voiding symptoms or voiding symptoms.
Okay.
And also would like to take history regarding the medications, if he is taking any medications and any intervention in past if he has taken for any.
He was hypertensive for 10 years. He was taking amlodipine irregularly, 5 milligram amlodipine irregularly. And there was no past investigations done.
And sir, history of smoking.
Okay.
And yes.
Anything else?
Sir, also we would like to know that anything past history of any surgery, prior pelvic surgery or urinary
There
tract
was no
surgery.
past history. He doesn't have any investigation. He was having LUTS, and for which he was not taking any medicines, and then he went into retention of urine. He is from a district, and he was on catheter for 3 months, which has been changed by the local people. So, how will you proceed? How will you examine the patient?
So we will start the examination of abdomen and genitalia.
Okay.
So we will first look for if there is any suprapubic tenderness, fullness is present or not. Then the status of catheter, and the status of
And
UM, if
also,
there is any
I would like
fissure
to know
fracture.
the TWC done or not.
And the digital rectal examination.
In the history, will you ask for a TWC, history of TWC?
Yes,
Has
sir.
been given any
History of
voiding trial?
voiding trial is important, sir.
Okay.
Yes, the patient is on the catheter since 3 months, and so we should ask about history of trial without trial.
He has been given a voiding trial which failed, and so he has been recatheterized in the same district nursing home.
We will proceed with the examination further, and we will do the digital rectal examination.
Okay. So what do you see in the digital rectal examination?
So on inspection, we see the perianal area, whether
Okay.
any excoriation, induration, or any.
You will not do the abdominal examination?
Yes, sir. We will do the
Yes.
abdominal examination for abdominal examination, and also the examination of external genital.
Okay.
Why do you want to do abdominal examination? I just want to ask a question, Ajay.
Why do you in case of chronic, not in this case, but in case of chronic retention, there may be.
Just wait.
He's already...
Just because an examiner asks you something does not mean you don't use your own brain. See, you have to be rational. He's on a catheter for 3 months. The catheter has been changed. There is no abdominal problem. What additional information you get on abdominal examination?
Sir, any scar mark, like any previous operated, like SPC placement or anything we can get. So that's why only inspection and part of my examination will be on. And whether in this case particularly there is no specific indication for the
renal angles, whether they are full or not, whether they are tender or not.
Yes.
In
Okay,
this
then
case, go with the case. What do you do? So you have to answer like now after your exam, you will be consultant. No. So you have seen such cases, or you have not seen such cases in the exam in your hospital. Have you seen such cases? So if you do, you say yes, I want to do it for this. If you don't, say don't.
Yes. Also, sir, I would like to examine the external genitalia, including testes. As the patient is on chronic catheter, he may have epidermolysis or chronic
yes.
Then, sir, with DRE.
Why a patient on catheter will have a epidermolysis? What is the common reason?
Sir, catheter-induced UTI is more common, and the antegrade, the retrograde spread of the bacteria to the testis via vas deferens, and so there is the epidermolysis.
Okay. Next.
Sir, we will proceed with the DRE inspection first to rule out any anal fissure or fistula, and then with on DRE we would like to examine the grade of the prostate, the medial circle palpable or not, and the rectal mucosa, the feces, the rectum is whether full with the feces or the rectal is empty, and lastly, the staining of the finger, returning finger. That all we need to know.
One more thing.
Sir, also,
one more thing.
Also know the consistency of the prostate and anal tone.
And
the most important, before you go proceed with the rectal exam, the prostate exam, you must see the anal tone and bulbocavernosus reflex. How do you elicit a bulbocavernosus reflex?
Sir, we gently we do the stretching over the diffuse or glance of the penis, and there will be the contraction of the and there will be increase in anal tone while we put our finger in the anal sphincter region.
Sir, actually, barbo-cavernous reflex is examined by two methods, by visualization
Yes.
and by palpation. And when the patient is on catheter, then the catheter is pulled upward and on visualize the perianal contraction or reflux.
Yes.
And in case of without catheter, if the patient is without catheter, then only squeeze the glands and with the index finger of the other hand to palpate the anal opening to palpate the anal perianal reflux or contraction.
Okay. So Ajay, so you will be now examining the prostate. How will you see the prostate? What is the normal? How will you examine the prostate? Digital rectal examination. What are the things you will want to know?
Sir, in prostate, first whether the finger can be reached above the prostate or not. Then the lateral, both the lateral surface and the medial surface is palpable or not. If there is any palpable nodule near the apex or in the overall prostatic surface, and the consistency of the prostate, whether there is the tenderness on prostate is present or not, and lastly, the mucosa over the prostate, the rectal mucosa over the prostate is mobile or not.
So you have to mention the size of the prostate, most important.
Yes, sir.
Size of.
So how will you measure the size of the prostate? Digital rectal examination, how will you grade it?
Sir, grade 1, in which there is we can reach the above. We can the finger can reach above the prostatic margin, and on the lateral side there is a lateral on the lateral surface. One finger can be placed in the lateral surface. On grade 2, sir, the upper margin can be reached with slight effort. And the lateral surface is again one finger big, and the medial surface is just palpable. On grade 3, there is upper margin of the prostate is reachable with great difficulty, but it can be reachable, and the lateral surface is deep. We can accumulate two fingers within the more than one finger within the lateral surface, and the medial surface can be obliterated. And
Okay.
grade
So
4, in which we cannot reach above the prostate.
okay, so in this patient, when you do the digital rectal examination, you found the anal tone was normal, and there is a hugely enlarged prostate. The prostate was smooth and firm. There was no nodule. It was non-tender, and I am not able to reach above the base of the to reach up to the base of the prostate. So what next?
Then, sir, we will proceed with the investigation.
What investigation we will do?
Sir, urine routine micro and culture. And then, sir, CBC and renal function test.
Okay.
And then serum PSA.
Okay. What else?
And sir, ultrasound for
Okay,
prostatic
so
volume and
in this
PCR.
patient, routine examination shows parcels of 10 to 12, RBC 3 to 4. Culture shows no growth, and urinary albumin creatinine ratio was 42.5. Hemoglobin was 12.1, total count 9,200. Liver function test normal. Urea creatinine is 42, urea creatinine 1.53. Sodium potassium was normal, uric acid 7.6, PSA 4.6. Chest X-ray normal, ECG right ventral branch block. And X-ray QB, there is gross degenerative changes in the lumbosacral spine. There is no radiopath calculus. Any importance to these investigations?
Yes, sir. There is
Anything abnormally found in this investigation?
yes, sir. In urine routine micro, there is 10 to 12 per cell, which can
That will be there
due
in
to
a patient with a catheter.
Catheter.
His culture was no growth. Culture he was
creatinine is
carrying.
slightly raised,
Slightly more than
1.5.
elevated.
Urinary SCR was 42.5. It is not showing. 42.5 and urea was 42 and creatinine was 1.53.
Creatinine is slightly raised.
What do you think the cause of raised urea creatinine? What do you suspect raised urea creatinine in this patient?
Sir, patient is a hypertensive male patient. It may be the one of the reason. And sir, other is there can be a chronic obstructive changes which can lead to the upper fat changes and which can lead to the raised urea level.
Okay. Recurrent urosepsis, recurrent UTI also might cause raised creatinine. So irregularly controlled hypertension, recurrent UTI, or there may be some back pressure changes which will know in the ultrasound. Because urinary, do you have any relevance for this raised urea creatinine in your future planning of treatment?
Yes, sir. There, per se, for the treatment plan, it will be not so much relevant. But the timing of the treatment, like if it is an acute change, then we have to wait till that urea creatinine need to be subsided. Like if there is
Patient
upper
is
fat
already
changes,
on
then
catheter. Patient is already
For
on
3 months.
catheter for
it
3
is
months.
3 months. Yes. So if it is a NADI value, then
We don't have any record.
we-
I told you before that he doesn't have any investigation. This is from district and he doesn't have any investigation. This is the investigation he was carrying. So what you will do? You will next investigation ultrasound.
yes, sir. Ultrasound period is first.
Okay. So this is the finding of ESG whole abdomen. There is bilateral mild increase in cortical echogenicity. There is no stone, no hydronephrosis, no hydroureter. Urinary bladder wall is thick, irregular trabeculated and containing mild debris. Prostate hugely enlarged, 7.6 into 7.2 into 6.5 centimeter. Around prostate volume is 158 ml. There is a large intravesical median lobe to the extent of 14 millimeter. So now,
Okay, sir. So,
what do you think the cause of raised urea creatinine?
sir,
So
here
back pressure changes has
there
already
is
ruled
a
out.
large, yes. So mostly, sir, the chronic uncontrolled hypertension may be the cause of the raised borderline creatinine.
Or recurrent UTI.
Recurrent.
He is already on catheter. He has a history of LUTs for 3 to 4 years. We don't have any record, but so.
So the prostate size is very much enlarged, and also there is a large enlarged median lobe, with there is no upper tract changes, and also there is a changes in the bladder.
Do you do a trial with without catheter in this patient?
Sir, in this patient, as there is so no upper tract changes is present, and there is changes in the bladder wall. But yes, sir, we can try a trial without catheter for this patient.
Do you think the trial will succeed?
So the less chance there is success on the trial, but yes, there is no contraindication for the trial without catheter.
What is IPP?
Intravesical prostatic projection.
Intravesical
how-
prostate.
Do you have a grading system of IPP?
So less than 5
Yes, sir,
millimeter
less than
is usually
5
grade
to
1
10.
and more than 10 millimeter, grade 3.
So 0 to 5 millimeter is grade 1, 5 to 10 millimeter is grade 2, and more
Grade
than
3.
10 will be grade 3. This is, you can see this thing. So how it is measured from the tip of the prostate up to the base. Okay, so do you think that you will succeed in this patient?
Sir, in account for large median lobe, the success of PWOC decreases accordingly.
Okay. So most in a patient with IPP of grade 3 is very unlikely the patient will succeed. His his prostate volume is very large, and also the interfacial lobe is very large. So there is no point in giving a TWC trial.
Yes.
This is the one. So how will you proceed? This ultrasound has been taken after removal of catheter to whether we can see to pass urine, and then when he could not pass the urine, so he has been recatheterized.
Sir, we will counseling patient. We will counsel the patient regarding the condition and the disease stage, and also regarding the comorbidity he is having and the creatinine level he is having. So based on that,
Okay.
we will plan our treatment. So patient is having sir hypertension with borderline raised creatinine, and also is having that right bundle branch block. For that reason, we will also do the echocardiography and possibly a cardiology consultation before proceeding for the further treatments.
Okay. So his echocardiography shows ejection fraction of 62%, and cardiologically has been given fit for anesthesia.
So we will counseling patient regarding the final definitive surgical procedure in terms of open prostatectomy, bipolar TURP, or laser surgery.
Okay. So what are the options in your case?
For open simple prostatectomy, sir.
Okay. Why we are
Bipolar,
thinking of open prostatectomy?
Sir, the size of gland is large, plus there is a large median lobe, so it will be more feasible for the open approach. And other options are bipolar TURP and laser treatment that are available.
Okay. So any other teacher want to ask any question?
You are specifying about, can you hear me?
Yes,
Yes,
Srinivas.
I am Dr. Narayan. You are talking about the open surgery plus the bipolar and the laser treatment. Which sort of laser treatment?
Sir.
What are the laser option available for this patient?
Yes, sir. Sir, laser resection is also available, and laser enucleation treatment recently has also available, sir. Holmium laser enucleation and or thulium laser enucleation of prostate.
Which is the laser resection method, dear, for 156
laser enucleation and laser vaporization, both methods are available.
Laser resection method, Hall wrap used to be a procedure, but nowadays it is out of use. Nobody uses it.
Okay.
Can you use green light laser in this patient?
Green light laser can be used in prostate evaporation of the prostate for the smaller size gland. But the result of enucleation with green light laser are not very much because it takes longer operating time.
You are right. You are right. This size of prostate is never conducive for green light laser. It's either only laser method available is vaporization, which is the secondary one. Primary is the enucleation, whether you use thulium fiber or you holmium. Holmium being the most common method, thulium fiber has come in a big way. Now people are using that also.
Yes.
You talked about the open. There are two kind of open operations, which are
Yes. Sir, it is suprapubic and retropubic approach. Suprapubic is described by Fuller and then like Freyers, and the retropubic approach is Millin's approach.
Which you will prefer?
Sir, for this case, I will prefer intravesical, that is Freyers.
Why?
Sir, there is a large prostate with a large median lobe protruding inside the bladder. So the prayer procedure will be easier. Although Miller's can also be done, but the prayers procedure will be good for the large medium lobes.
Larger prostate will also easier for
Large
Millin's
medium.
also, because the prostate
Yes,
will
sir.
be
Both method can be done, sir.
just because
Median lobe
it is a
will
large median lobe, that you will avoid the Millin's prostate is not like that. Anyway, when you give a transverse incision, the median lobe can be accessed from there itself.
What are the difficulty which you will face if you plan for a bipolar TURP, as you have been telling? What are the difficulty you will face with this size of prostate?
Sir, it will take a longer resection time for this type
Yes.
of prostate 160 cc. One, it will take longer resection time, and the other thing is
Long
Longer time is
natural
one thing.
instrumentation time.
longer instrumentation per ureter terms.
It's very difficult to handle a 160-gram prostate with any sort of resection procedure, be it monopolar
Yes.
TURP. Monopolar you cannot try. Bipolar, it is the blood loss, fluid absorption, apart from longer operating time. It's not very easy. So if you are given an option, I suppose that you are well versed with all the procedures, be it laser, bipolar TURP or open, which you will choose.
Sir, if I am trained in laser surgery, then laser enucleation, Fullian laser enucleation prostate will be more preferable method. But in a sub-center, we can have bipolar machine also. So bipolar TURP can also be done.
What are the newer modalities which are getting popular now for doing such sort of prostates? See, bipolar is fine. It's a more than 10 years now, and open is okay, fine. A lot of people are not exposed to that. Those who are fortunately can do that. What are the new techniques which you can see, and then you can say, oh, I have the facility, I'll do it.
Okay, sir, like robotic.
Either laparoscopic or robotic enucleation of the prostate can be done safely.
Yeah, robotic simple enucleation of prostate or laparoscopic enucleation.
You can do that if you have not seen, but in the coming days, it is getting very popular now. So open is going to laparoscopic way. The principles remain the same. You can do a Freyer's or you can do a Millin's depending on your experience, and you can do it laparoscopically or robotically. So if now given an option to you as a candidate, in what category you will start putting the procedures and why? So the surgical intervention is must. So that is dedicated. Now, what intervention? 1, 2, 3, 4 in that criteria, what would you put it? And
Sir, first I will put sir, Fullian laser enucleation of prostate, laser enucleation of prostate. Then sir, bipolar TURP, and then
enucleation is one of the ways of doing it. You can use a laser. You can even do a bipolar enucleation. You can even do a monopolar enucleation. So enucleation becomes one category of treatment. Resection is the other category of treatment. And third is laparoscopic, either Freyer's or Millin's.
Okay. Any other teacher?
What complications do you expect in them? In such patients, what is the complication? The most common complication you will encounter if you are planning an enucleation or open Millin's or laparoscopic or robotic Millin's? What do you expect in these patients? what is, in short, what is, if you do a resection of a patient, what is per gram expected loss of blood? You're planning a surgery, you don't have, patient doesn't want to go outside, and either you can do, is there an option of a patient says, I don't want to go out, you don't have a laser, patient says, no, Dr. Saab, I have full faith in you, whatever you do, I'll accept. You have not seen an open surgery. So what is the other option now? Open आपने देखा नहीं है. What will do? Bipolar.
Bipolar or yes, sir.
Monopolar. So what will you explain the patient? With a 160 grams prostate, you're a fresh pass out, but the patient has faith in you. Say, no, Dr. Saab, you will only do it.
Yes, sir. So we will counseling regarding the need of multiple session of treatment. And
good.
Also,
so you can tell them that we can do a space procedure in you.
Stage resection.
That is not this thing. If patient doesn't want to go out, you are well within your rights to tell them, but you have to inform the patient. And secondly, arrange
blood.
Blood. 1 to 2 units of blood should be kept in hand.
That is what my question comes to. What is the per gram loss of blood in TURP? Then you have to read that. So one question you have to read now. Per gram loss in blood. So that is accordingly that only you will counsel your patients. And what is the resection speed of a good resectionist?
1 gram per minute.
1 gram per minute. Good. So you have to, by the time you reach there, if you're not able to do that, so with the improving instrumentation and the cautery, the quality of the cautery and the cameras, so you can always have 1 gram per minute, and you can go up to, with bipolar, you can go up to 2 hours. That is not an issue.
So, Kamal, suppose this patient, you succeed with this patient or a similar patient, you succeed with trial without catheter. So how do you follow up this patient? Suppose you give a trial and the patient started voiding and the patient refuses surgery right now. How will you follow this patient? Patient refuses the surgery, he will do the surgery after some time, after a month or after 2 months. How will you follow up this patient?
First of all, I give the.
And what are the risk of, what are the complications you expect in the follow-up period?
First of all, I will put the patient with alpha blockers with 5-alpha reductase inhibitors because of large prostate more than 40 ml, and also regularly check up the patient with a regular follow-up with the patient with a USG with a PVR or serum creatinine levels, or either there is in USG either there is changes in the upper tract or bilateral hydronephrosis developed or not, or there is a renal insufficiency developed or not, and also uroflowmetry should be done to check the Qmax and the wadded volume.
So you list the complications 1, 2, 3, 4. What do you expect? First complication may be the immediate AUR.
Immediate retention may be occurred in the
after few days. Future.
Yes, and recurrent ETA can be.
Why should that be the, Dr. Kamal? What is the incidence and relationship of, like sir said, acute retention of urine again with median lobe? What is the relationship of that, and what is that paper which has given the criteria for probability of going into failure again with the size of the median lobe? That is a landmark paper. You will have to read that. You can't see this is the size of the median lobe, and you have to have that. You should know that paper. What is the probability of going into the retention again with what size of the median lobe? Anybody else? Sir. Dr. Anik, can you show us? No, you're looking Google. I hope you're not watching Google at present, huh, Anik?
No, sir. No, sir.
No, and Ajay has gone, huh?
Yes, sir.
Ajay has disappeared.
No.
So there is a landmark paper by Katie Fu, who has very nicely predicted what is the size of the prostate and what is the probability of acute urinary retention when you remove a catheter in such patients. So you all should know that. That is a very important paper, clinically relevant paper.
Yes, sir.
So other complications, Kamal?
Patient may
One is
present with
retention.
recurrent UTIs, and
Number
maybe there's a development of the bladder stone in future, or diverticulum,
Okay.
or maybe a patient present with the hematuria, or
Upper tract changes, azotemia.
yes, sir already told that there's a maybe chance of raised creatinine or bilateral hydronephrosis development and the upper tract changes, or renal insufficiency may occur in long.
And what else? Bladder decompensation.
Yes, maybe there is a development of the trabeculations and bladder wall thickness, and the lastly
Bladder
diverticulum.
decompensation.
Diverticulum may develop.
Okay. Srinivas,
Kamal,
anything?
Kamal,
Yes, yes, sir.
sir, Dr. Anjan Das is specifically asking you enumerate those complications rather than giving a detailed information. You enumerate
1,
what
2,
is the
3, 4, 5, 6.
1, 2, 3, 4. First, as everybody told, when a patient with this size of retention,
Sir,
acute urinary
retention,
the patient will end up
recurrent UTI,
recurrent
hematuria,
UTI,
raised creatinine or renal insufficiency, and
renal insufficiency.
bladder wall thickness and changes in the bladder wall, trabeculations.
Atrophy or dystrophy, whatever you tell. These are the things which you will forewarn the patient if he asks for a medical treatment in this condition. If he is adamant that I am not going to undergo surgery, please give him medication. You must tell to the patient these are the complications you might face if you are
Yes,
opting for this medical treatment, and you ultimately will have to get yourself operated.
Yes.
So you have to enumerate those things rather than giving details of about every complication.
So can we go to the next case? Anybody?
Yes, sir. We need to keep some questions for others also.
Okay.
For other cases also.
Okay. Can you anybody?
Hello. Yes, sir. We
Yes.
can go to the next case.
Next case.
Yes, sir. Actually, almost the evaluation and basic approach to a case of prostate is almost same in many cases. We just want to know the what are the critical differences in evaluation in specific situation, and probably in the next case we'll see the changes. What in other situation how the students should approach during examination. So next case is to be mentored by Dr. Rahul. So
Okay.
it's over to
I'm
Dr. Rahul.
I'm stopping sharing.
Yes, sir.
I've stopped sharing.
Dr. Rahul, please take over.
Sir, okay. Thank you, sir. Thank you for having me. Do we have a case for this thing?
Do you have
Because-
the case list, or you did it from the post?
No, I don't have a case. I was not aware that I have to prepare. I thought the cases are with the.
Okay. Just a minute. Nimalia,
I was told that cases would be there with you.
So can you please send me,
purpose.
then I can share, sir.
Yeah, please
Yes,
share the
second
case and then we'll take it from there.
Sir,
before they share, we can have some discussion and overview if you want to add anything regarding last case. Hello. Hello.
Yeah. This second case was.
I think regarding last case, it's a very tricky situation for any urologist by any experience, and for exam it's really difficult. So there is a possibility that possibility of retention. There is one study. What is the successful chances of avoiding fail? Second, what exactly the procedure to be chosen, and open surgery is not wrong. That has to be taken care. And particularly during exam, the student must answer what they can do. That is the basic thing. Many students usually miss during examination. What happens? They usually used to tell this is the best method. What you will do? Then they will tell the best method. I think during exam they should tell what exactly they want to do, what they can do. That is the
and that also reflects what they have seen in their 3 years of tenure in working in a particular institute. So, and if they have seen that happening successfully, there is nothing wrong and right. It is all what you have seen, and you're going to practice that only. What X person can do or Y person can do with the facility is something very different. We have to see that how safe and what you're talking. Anyway, so basically the second case was regarding BPH with stones. What I can see on this thing. Was that Dr. Sameer?
Okay. Yeah, no. So, Nirmala, is it available? I can share it.
So
just one ultrasound picture will also do. No issue.
Just send me the file, sir, so that I can share, sir.
No, file we don't have. I don't have. Otherwise, I could have shared.
Samir, do you have any prepared case?
No, I think.
Samir, that is Samir.
Hello.
Yes. Do you have any prepared case?
Right. I don't have actually. I thought the cases will be there. There was a confusion regarding this actually.
There was some confusion. Otherwise I would have prepared. I have cases, but
okay.
No, okay. The 3 cases.
Can I share one more case?
Yes, sir. Please share. Please share that. That can be. By
the side who is
Professor
supposed
Das,
to
please go ahead with another case.
So I'm sharing another case.
Okay.
Next student, please be ready. The 2 students will be there. So he has joined. Hello. Hello.
So yes. Can you see my
this
screen?
Is a good case.
Can you see my screen? Case.
Yeah, we can see the screen and nicely.
Okay,
so this
is
a good case.
68 years male, known case of diabetes for 12 years. He is hypertensive for 4 years.
Dr. Das, please select the students who will be answering to your question.
The next 2 students, please identify yourself from which institute and your name.
Sir, I am Dr. Onik Ghosh from Archikor Medical College and Hospital.
Okay. Who else?
And 4th one probably not join. So anyone from the first case can join.
All
yes,
3
sir,
can
Ajay
join.
Yes, Ajay and
Anik.
Okay.
So Anik,
okay, good.
Yes, sir.
This is a 68 years male patient who has a history of diabetes for 12 years. He is also hypertensive for 4 years. He has a history of poor urine flow, intermittent retention, incomplete voiding, and occasional hematuria off and on for 3 years. He presented in emergency. This is for last 3 years. He has been having poor urine flow, intermittent retention, incomplete voiding, occasional hematuria off and on for 3 years. He presented in emergency with frank hematuria and retention of urine, fever, and lower abdominal pain for 2 days. He was catheterized in a district nursing home, which is draining frank blood, blood-stained urine with intermittent catheter blockage. On examination, patient was restless in the emergency, febrile, bladder was palpable and tender. And digital rectal examination showed anal tone was optimal. There was an enlarged prostate of 50 to 60 gram, smooth but tender. So how will you
Yes, good.
proceed?
Yeah. So Anik, what is the diagnosis? Looking at this patient, what do you feel he's suffering from?
Sir, with the history, my first diagnosis will be hematuria due to carcinoma bladder or hematuria due to benign prostatic enlargement.
Okay, fine. 2. So what is the incidence of hematuria in BPH in a normal patient? In a normal BPH in your OPD clinic, what is the incidence of hematuria and BPH? You don't know. Okay, fine. Ajay? This is a very simple question, boss. This though you should be knowing. The amount of hematuria with BPH. Our other candidate. Ajay?
Around 10 to
What is
12%.
10 to 12% is a big percentage, boss. 10% is a big number. It's not 10%. And what is your differential diagnosis? As Dr. Anik said, he has 2 differential diagnoses. One he said was hematuria because of malignancy. Another he says hematuria because of BPH. So what is your differential diagnosis, keeping whole of this picture in view?
Sir, hematuria due to UTI or hematuria due to BPH.
Good. Slightly better. Why hematuria? What you feel? What question you should ask when this such a patient lands up in emergency? The first question, what would you have asked to the attendants?
Sir, whether
He
this
has come to you.
hematuria is
Yeah, hematuria is?
whether this hematuria is painful or painless.
No, wrong
or
question.
associated symptom.
No.
He is
See,
already
this
having
patient.
pain.
Okay, he's restless, he's pain, he's fever, and he has a catheter draining frank blood. So what question? First question you should ask this patient. When you catheterize a patient, what notes do you put on your sheet? You may be working somewhere. A patient comes to you. He says, "I'm not able to pass urine." He has a palpable bladder. He is diabetic. You say, "Okay, Shay, I'll put up a catheter." So you put up a catheter, and what do you do then? Or what do you write for any catheterization? What notes do you write on your sheet? So that you don't have that sheet with you because the person who has put a catheter has not written anything. The patient's attendant don't know anything. So what would you do when you put a catheter? Ajay, how do you write the notes? You don't write anything. Anik, what do you write?
Sir, the amount of the urine collected.
No.
Color of the
First
urine.
thing is you write is with the ease of catheterization. Was it easy or what is difficult? Then you write the number of which size catheter you were placed. Third is what is the amount of urine you have drained out immediately. And fourth is
Color.
Fourth is
Color and consistency.
color of the urine. So had that previous fellow written all these things, the life for you would have been easy. So you can ask the attendants who was accompanying there when the catheter was put, and you can get all the information there. And the most important is what was the quantity of the urine drained itself. See, I'll put it this way, that this patient is a diabetic, long-standing, 12 years. You should ask what is his diabetic status has been to the attendants. Very important. If they say it was off and on control, that shows he's uncontrolled diabetic. He may have a BPH. He may have a palpable bladder. He may have infection. Somebody has put up a catheter. He started with hematuria. He got afraid and he sent the patient ahead. Am I right? Can you understand what I'm saying? So that is not a very rare situation to be in. Kyo, Anik? Is it right? You agree?
Yes, sir.
Now that
Yes,
patient
sir.
has come
Yes,
to
sir.
you. Now the patient has come to you now. So we don't have the prior information. We go by the story I have told you that the patient would have had a chronic retention, acute on chronic. He would have been in fever. He would have had before also some plus minus control of diabetes. He is hypertensive and somebody has put up a catheter, sudden drainage of bladder, and he is presented with hematuria. Now the second question to the exam going students is, what is the probability of hematuria on sudden decomp? Do everybody get it? Or what is the percentage? How many people would get hematuria on this thing? Arey, aap padhte nahi hai yaar. This is written in the book. The patient will ask you, why do you want to do a slow decompression? Why don't you put up a catheter and go back? What will you tell the patient? So yeah, this question you should know. The answer to this question you should know. Second is, now the patient has come to you. What would you do now? He is bleeding actively. He is febrile. He is bit slightly restless. So what do you do now?
Sir, as the history suggestive of there is intermittent blockage due to the hematuria, and I will try to institute bladder wash or bladder irrigation. So I will want.
No. Anik, you choose your words. You want to do a bladder wash or you want to do irrigation? They two are very different things. Bladder wash is different.
What Rahul is asking, what will do? You will first admit the patient.
See, what is this picture? This picture tells you that is in urosepsis. Is it there or not?
Yes, sir.
Is in urosepsis. Blockage is secondary thing. First, you stabilize the patient. You should be asking for, sir, I want to know the BP and pulse of the patient. Is he hypotensive? What is happening? Does he have a Medicat? Have you have a drip access to venous access to the patient or not? What is his blood group? These things can be done while you are putting a Medicat to the patient. See, what we want to know is how safely you will manage the patient. Clot evacuation or clot wash is the last thing you want to is on my mind at present. My mind is to stabilize my patient, put some antibiotic into his veins, have him stabilized, send a sample. For what test would you like to do in urosepsis? Dr. Ranjan has written a very good article on urosepsis. Have you people read that? Even I got educated by reading that article.
Thank you. Thank you.
And it is a wonderful article, sir. They will read that. But what are the investigations you send for such patients? Chalo, ye batao mere ko. You are putting a Medicat. You are a very intelligent man. You will say, "Bhai, I want to while the putting I'm putting Medicat, I'll aspirate some blood and send for 1, 2, 3, 4." Chalo, Anik, bolo fatafat.
Total complete blood count.
Good. 1.
Serum urea and creatinine.
RFTs. You send the RFTs. RFT will include serum urea, creatinine, and most important,
serum potassium.
Serum electrolytes.
Potassium. Electrolytes.
Potassium and sodium, because he is restless. You never know. The reports will come later on. What is the third thing you'll send it for? If you are working in a higher center, what do you send it for? He is febrile.
CRP.
CRP. Good. 1. More specific.
Okay.
Yeah, good. It is the PCT levels. So now you should inculcate this habit of getting the PCT done. That is a procalcitonin levels, which are more specific for sepsis than anything else. And preferably one more test, which if you don't say, okay, I will not, but if I would be there, I would send a blood culture immediately. Because the patient is in sepsis, urine you cannot send because it is all blood from below. So at least you send one, because you're collecting the sample. No, you have not put an antibiotic into the blood yet. You send a blood culture in the one go. And then now you have time till the reports are coming. You can ask the patient things and start him on. So what would you do?
Anik, these are the reports patient was carrying from the nursing home. You could see the total count is for 14,200, CRP 26, fasting sugar, PP sugar, HB1C, and he was carrying an ultrasound which shows bilateral kidneys are normal, no hydronephrosis, no hydroureter, no stone. Bladder distended, full of clots, and prostate is around 65 ml.
This is a
now
difficult case. What would you do?
You have admitted the patient. This is the reports he was studying.
So now what do you do?
Onyx, say what you do normally in the war. You don't have to read out from the book and say all these answers.
You can't take
sir, I will medically stabilize the patient at first.
Okay.
Fluid and resuscitation, and along with IV antibiotics.
Very good. Great. What antibiotics is the antibiotic of choice would you like to give in these patients?
A broad spectrum gram-negative coverage antibiotics.
Good. Good.
এখানে লেখা
So
আছে
you have given the
stabilize
antibiotic,
patient
patient is
of-
stabilized, patient on
প্রথমে
drip,
যদি অত বড়
he is
chapter
well
আছে,
hydrated. Now
তাহলে
what
আমি
you,
এই
now
পুরো
your
10
focus is
মিনিটে
on,
complete করতে পারবো না। আমার কাছে
now
তো
what you,
ক্যারি আছে, ওতে টিআরপি
Then I
টিআরপি
will try to give a bladder wash
সেটা আমি
to
করেছি।
clear out the
অত
with,
clots.
all of
What
you
is
in
what,
front of the
retention?
people,
কিন্তু
please
বহু
mute
কথা
how
yourself.
do you
Please
give bladder
mute
wash?
লাগে,
yourself.
চাপ লাগে।
There is a background music, words.
উনি ওনার নম্বর দেওয়া ছিল কমিউনিকেটর। আমি
So-
সেই করে আজকে বসে আমি কালকে সানডে বসে সন্ধ্যাবেলা সময় এটা করেছি। বসে
Sir,
বসে।
somebody is talking, you expect.
Dr. Srinivas, please mute this.
So Anik, what do you do next? Wash, how do you give bladder wash in such patients? With what, where and how?
Sir, I will try to institute a three-way Foley's catheter.
Okay.
Uh,
You should always give the
uh,
number of the catheter, what number you want to put.
Sir, 22 French will be my choice.
Okay.
And with the help of a 50 ml bladder wash syringe, I will try to give a bladder wash with that catheter, so that the
Okay.
clot will be evacuated. And after clearing out of the clots, I will institute a continuous bladder irrigation with 3 liter NS.
Okay, fine. Good. So now next slide, sir. Dr. Anjan, next slide. Can we have a next slide? Sir, you are mute. Dr. Anjan, you are mute.
May I
Oh,
go to another question? I'm sorry, Dr. Sudeep Chakraborty.
Yeah,
He
yes,
has
sir.
said
Please,
that he
please.
will give the bladder wash through this Foley's catheter. But suppose this huge amount of clots are there and bladder wash through Foley catheter is not successful. What you will do? Put the question. And where Dr. Gupta asked where it will be done. Means in the ward, in the theater, and what you need next.
Sir, if
much
bladder
of
wash
clot.
with three-way, sir, if bladder wash with three-way Foley's catheter cannot be done, then I will try to give a bladder wash and clot evacuation under anesthesia in the operation theater.
Under anesthesia?
You will
Okay.
put
As
general
basic.
anesthesia or spinal anesthesia or what, local anesthesia?
Sir, preferably it will be done under general anesthesia.
Oh God, no.
Nobody will give you.
Mostly
Anik,
it is
this is the wrong
located,
answer.
no.
Nobody
General
will give general anesthesia.
You must
You
remember
don't-
anesthesia has got so much of hazards, and in such a patient when he is febrile and all these things, why unnecessarily you will do?
So what is your aim of giving a clot wash? What is your aim of doing it? Let's start from there. So then we'll come to anesthesia. Bolo Anik, what is your aim of doing a clot wash? Fast.
Sir, to prevent refractory retention.
Okay, one refractory retention.
Sir, clot
think so.
retention that is occurring intermittently
Clot
for last 2
retention.
days.
So that means in such a patient, what should be in your mind? Quick in and quick out. Okay.
Yes, sir.
You don't have to see if the bleeding source you can't find. You don't waste your time in doing that. So what would be a preferred anesthesia means medication. 65 years old, 12 years diabetic. You don't have a history. You did not ask him whether he's on antiplatelets or not. Nothing. Neither you can give a spinal anesthesia. Suppose he's taking antiplatelets, which is very often in these patients. You can't
Yes.
give spinal. GA you have not prepared. So
It's a
what is the harm
sedation.
in doing local anesthesia? What is the harm in doing local anesthesia in such patients? His creatinine is normal. Give him a shot of Overon. Make him comfortable.
Already the bladder is full of clots, and if I am doing it with local anesthesia and during the clot evacuation, I am giving more NS, the bladder will be more distended and it will be painful. The patient may not tolerate.
No. How does the clot evacuation change under anesthesia versus under local anesthesia? How does that change? I'm not able to get your point. How does clot evacuation is different under local versus GA versus spinal? What happens? You want to tell me under GA the bladder capacity increases?
No, sir. The pain sensation by the patient.
You give him Overon, put a jelly, keep it for 15 minutes. Go in and do it. Obviously, it is a compromise situation, no? So, but you will make it complicated from compromise. You want to make it complicated by giving him GA? GA is not acceptable, neither spinal. You have to do it under local. Whatever clots you can get rid of, put a catheter fast, start an irrigation, and then wait, just sit on it. You can't I don't think anybody would give. I agree with Dr. Saab that nobody would.
Other
Yes,
than
the
CA
thing
Foley's
is
catheter, any
absolutely.
other catheter would you suggest to get rid of this situation? What is the problem
said,
in doing clot evacuation with a Foley's catheter?
He said
Do
he
you
will do
think
that.
any
He
other
said he will do that
catheter?
first.
No, mostly in most of these situations, this through the Foley catheter, it may not be possible. You see, such extracting huge amount of clots. And the thing is, under local anesthesia, of course, the situation will be uncomfortable for the patient, no doubt. But you can ask the anesthetist to stand by and give some sedatives along with this local anesthetist through the urethra. And you just do the pumping with elixir softly or rather gently. And you can, most of the situation, you can do your job properly. There's no harm. Only little sedation may be needed.
There are some
Dr.
special
Rahul,
catheter available.
Dr. Das,
Sorry?
for a while, just a minute, Dr. Rahul, Dr. Samir.
Yes.
Not here.
Dr. Rahul.
Hello.
Yes, sir.
Hello.
Hello.
Dr. Rahul, please take over. I may be excused, maybe having some urgent work.
No issues. We can carry with this case, or what is that you want?
You can continue the case and continue the session also.
Okay, no issues. No issues. No issues.
No.
Don't worry. Don't worry.
Thank you, sir. Thank you.
So Dr. Anik,
Anik?
what I was telling, that if there are some special catheters available, do you know what is called hematuria catheter, which comes by with pouches with a large holes without any balloon.
Anik, have you seen such catheters? Hematuria is very right.
No,
Hematuria catheter, have you seen that?
No, sir.
No, sir. Okay, fine. So okay, fine. You then should say I have not seen, sir, in our hospital.
These are steep catheters. These are steep catheters. They doesn't collapse, and they have a very big holes. So usually, sometimes you succeed in such a situation where you cannot give in anesthesia in an emergency situation.
So now you have done a good clot evacuation. It is out, and you put a 3-way catheter. It started irrigation. So now what would you do?
Dr. Rahul, just interrupting for a while. Hello, Dr.
Yes, sir.
Rahul,
Yes, sir. Please.
can you hear me?
Please, sir.
Yeah.
Please, yes.
Dr. Samir Swain is leaving.
Yes,
Please
sir. I know.
continue as the moderator.
Yeah. I know, sir.
Thank
No, sure. Thank you.
Thank you.
So Anik, now the patient is having irrigation. He was having fever. His counts were high. Now you have admitted the patient. You have done a good job. You did a clot evacuation. Now you started irrigation. The color is settling down. So what would you like to do now?
Sir, I will do some imaging studies.
After how long?
Sir, after clot evacuation.
You have done at 6 o'clock evening. You have done a clot evacuation. Patient is in the ward. He's overnight. Tomorrow morning, next day morning, you have come for the rounds. You find that the hematuria is settling down. So what do you do next?
Sir,
Continue tell me, Anik.
Sir, I will do an imaging studies.
The next day itself.
Dr. Rahul is asking what to do. The next day you'll do the imaging study, or you'll do some conservative treatment. You'll continue the antibiotics. Let's total count, procal, and CRP comes down in 3-4 days time.
Sir, after
keeping the
settling
patient
down
under
of
observation.
Sir, after settling down of the situation and keeping the patient in observation, and after that I will proceed for further.
You have to speak all these things, Anik. These things are not taken as granted by the examiner. So if you don't speak like that, then you're a very unsafe urologist. So if you tell me that you want to do an imaging study next day morning on the rounds, so nobody will accept it. So you have to see whether the patient has become afebrile, how patient was restless, how is he now behaving, whether he has become calm, he's accepting your commands, he's able to talk to you, his fever has gone. What is the hurry of doing a imaging study? How will that change anything in that patient? You getting my point? That is not
Yes,
going
sir.
to change your management. You don't do an investigation which does not change the management of a patient. So as
Yes,
of
sir.
now, what is your diagnosis for this patient now? So let us talk about that. What is your diagnosis now? You've done a clot evacuation for the patient. Now, what is your diagnosis? What, retrospectively thinking, what you have admitted a patient with what, and what? Let's talk about that.
So retrospective, the diagnosis is hematuria due to benign prostatic enlargement. Hematuria
That's all.
with
Hematuria due to urosepsis.
Exactly.
hematuria with
Hematuria
urosepsis.
with BPH, with diabetes, with hypertension. That is a complete diagnosis. See, everything is important, no? His hypertension is important because his hypertension, maybe that has led to his bleeding. How do you know? He is diabetic, his blood vessels are not very healthy. His blood, because of that, you don't know. He came with fever, you never know. Because of that, he has bled in. What has happened to the patient? So we have to take care of all these factors before you go ahead and do any imaging study. So how would you answer in the exam? So now again, I'll ask you the same question. So after discussing with you, what would you answer now? So now you have come for the rounds the next day. What is your approach to the patient?
Sir, this is a case of hematuria due to
Okay,
benign
how would you
prostatic
proceed
enlargement.
now? How would you proceed now? What are you planning to do for the patient now?
So I will repeat the investigation.
Good.
Or other investigation along with urine analysis, and will assess if the emergency situation for this patient has been settled or not.
Wait. See, you started well. Then the 3 liters anesthetication on the patient. So what would you like to do a urine analysis now? You have already given an antibiotic to the patient.
No,
So what urine analysis you will do now?
Hematuria. So
Hematuria
if
is
the
settling down.
hematuria, and after irrigation has been stopped, then we proceed for.
No, but you will not do the other investigations. His hemoglobin was 9.2. After clot evacuation, his
Again, you are getting
hemoglobin might
confused.
come down.
You have is more important investigations. You have already sent antibiotic is already inside the blood of the patient. Urine analysis will not play any role now. So see, whenever you answer, you think before. See, you can do any investigation. That is not an issue. In the exam, you will have to defend that investigation. So doing an investigation is not a problem. Why do you want to do a urine routine? I would not accept as an examiner that you want to do a urine routine in a patient who is already on antibiotics, who is already on a catheter, who is on an irrigation. You have a better investigation to do. Hemoglobin, see whether it has come down to 7. You do a TLC repeat. You see what has happened to that. You do his sugars, see where his sugars are. You do a sugar answer should be, I would do a sugar charting, see how his sugars are controlled or not. What is his temperature chart, whether his temperature has come down or not. I would do his CBC again to see whether his hemoglobin has fallen. Do I want to give him some transfusion and see whether his CBC has responded or not. Rather than doing a urine, is obviously he's having a urosepsis. The urine will not help you at all at present. You get my point?
Yes, sir.
Okay. So now let us take it further. So now your patient is stabilized completely. He's off the irrigation. His counts are normal. Hemoglobin is acceptable now. You have transfused. You build up the patient. Now what investigations you want to do in your patient that he should not suffer the same again? Ajay, what would you do now?
Sir, I want to confirm my findings on cystoscopy and bladder evacuation that I have done already. That whether there was any particular point of bleeding was identifiable at that time.
No. That time it was an emergency clot wash, so he has not been able to see anything. It was a quick in, quick out. No information is available. It was all red.
Right. Sir.
So you will
Right.
be taking again to the operation theater without knowing the upper tracks.
Yes, sir. So,
Cystoscopy will only see
for
the
that
lower
I
tracks.
would like to do, sir, imaging
Sir.
of the upper tract in terms of CECT KUB, sir. With
Oh.
CT
You want to do a
urography.
CCT KUB, whole of the things.
Yes.
Why do you want to do a CCT KUB?
Sir, to know the origin of the to know the cause
See,
of the
the
hematuria.
ultrasound is already there. They say no hydronephrosis, no hydroureter, no stone. You see
Yes,
the
Sir,
sir,
if
but
ultrasound, no?
there is any
sir,
upper tract
there
urothelial
there
carcinoma, that may also
Sorry?
there
predict
can
good
be
hematuria.
TCC urothelial carcinoma in upper tract, sir. That can be the cause of the bleeding hematuria at that point of time, sir.
So see, so hematuria causing clot evacuation without causing any problem in that particular kidney. You want to tell me that? See, again, I'm telling you, you have to use, you should think before you order an investigation. See, not every hematuria you need a CECT. See, a significant hematuria, which will lead to a clot retention in a patient without any hydronephrosis in that particular ipsilateral kidney is very unlikely. You get my point, what I'm saying?
Yes, sir.
Yes, sir.
See, if it is a microscopic hematuria or a patient is voiding and he gets intermittent hematurias, yes, then you can do a CECT. No issues about that. But the patient who's presenting with a clot retention, with fever, with normal upper tracts on ultrasound, CECT as an upfront investigation, I am not. I don't think that is the first investigation you want to do in the patient. With the aim to find the TCC in the upper tracts, that is a very far-fetched things. So, what investigations would you order otherwise?
Do you want to repeat an ultrasound? Because the
Yes,
initial ultrasound was full of clots.
Exactly. So what do you do? Would you
Yes,
like
sir.
to do something?
the repeat of ultrasonography.
Repeat, at least do an ultrasound, see what is happening. What was the size? Because of inflammation, the size would have gone up. Now you look at the size would have come down because of inflammation. So you look for the bladder. Bladder as a source of hematuria causing clot retention is more likely than upper tracts without hydronephrosis. So there is a small bladder tumor inside associated. Now his urine is clear, clots are not there. He will be able to screen the bladder, full bladder ultrasound. So if I was you, I would answer said I would like to repeat a full bladder ultrasound again to look for any cause of hematuria from there. If it is negative and the patient is persistent hematuria, then I would like to screen the upper tracts. You can't do, because CECT is available, you can't do a CECT upfront in such patients. Okay, Ajay? See, whenever you speak in the exam, be very sure what you want. Don't just because you want to say something CECT, and I don't think a sane examiner will accept it upfront. And that is not the way you want to treat the patients. Somebody would say you are over investigating the patient. So now the patient is fit for discharge. He says, okay, doctor, sir, now I'm fine. Thank you very much. So now my counts are normal, hemoglobin is good, there is no hematuria. So what would you suggest? You would tell the patient that you go home, or do you say, no, I will operate you and send you? What is now? How do you approach the patient now? Patient is fit, everybody is happy, family is happy with you. So now what do you want to do? Let
Sir,
the patient go home?
if this is a single episode of hematuria, this was the only single episode of hematuria, and there was no past history, and the probable cause of the bleeding is I am suspecting as a prostate, then I would like to counsel patient regarding that this may happen, that he may have this similar kind of hematuria, and at present there is no indication of going for surgery. But if this bleeding hematuria, there is recurrent episode of hematuria, then there may be an indication of going in and doing this surgery. So at present, I will advise patient for a conservative treatment on medical lines.
On medical
So if
lines
the
and
Uh,
when
sir,
patient says,
with
okay, fine, doctor, we are starting me on what medication?
Sir, we will, as the patient had already episode of hematuria and prostate size is 60 cc. So we would like to start with one alpha blocker and also one 5 alpha reductase inhibitors.
Okay. Did you see the investigations of this patient?
Yes, sir. The PSA previously was 12. So I would also like to repeat PSA before going for starting of 5 alpha reductase.
That is very important, because in the start of the session, it was a very nicely taken a class that you don't start dutasteride upfront. Do you feel this PSA is the right reflection of his PSA, or is it a false reflection of his PSA?
No, sir. The PSA was done at that time was in urosepsis, and also there was finding on DRE that prostate was tender. So that time of PSA should not be considered as a baseline, and After subsiding of this episode, we should repeat PSA after 6 weeks, and we should consider that PSA as a baseline PSA and make our decision based on.
So would you wait for 6 weeks to start dutasteride, or you would start dutasteride upfront?
No, sir. We should wait for 6 weeks for.
Okay.
But yes,
So-
if there is any emergency episode of hematuria, recurrent episode of hematuria, then we can.
So your answer should be that, okay, fine, you can give an alpha blocker. What alpha blocker would you like to give, and when would you call him for a catheter-free trial? TWOC when? After how many days?
Yes, that's the thing. The catheter has to be removed. They have not mentioned, Ajay, whether the patient is without catheter or with catheter he will be sent. That's most important.
Sir, he
While
wants
the
to give
situation
a.
is improved, nobody, I mean, none of these students have told that they have removed the catheter and watched and what happens.
No, sir.
So
They said
after
that.
Sir, I
removal-
would like to send. Yes, sir. Sir, I would
Yes.
like to send patient with catheter as there was a episode of AUR with hematuria and urosepsis. Again, AUR can cause more damage and the recurrent UTI. So I would like to call patient after 1 week, and we'll give silodocin as a drug of alpha blocker, and we'll call the patient after 1 week in OPD for the TWS.
What is the normal definition of TWOC? After how long can you give a TWOC? This is what you will do. That is something different. What does the literature show?
Sir, after 48
3 to
hours
5 days.
of the initial catheterization, if we are giving a voiding trial, then it is a
If you're giving a
voiding trial, catheter-free trial.
on
under
what drug?
the alpha blocker.
What drug is the fastest? In short, what the examiner wants to know is which is the shortest and the
Silodocin.
fastest acting alpha blocker.
Silodocin.
Silodocin.
Silodocin. Okay, fine. So if you are starting the patient on silodocin, after 48 to be as a safe candidate, if I was a candidate, I would never see one word. I would say 48 to 72 hours.
Right.
If I am starting on silodocin. But if it is I am starting on alfuzacin or tamsulosin, then I would wait for 5 days and then give a voiding trial. Okay. So, and according to what happens during the voiding trial, you will have to plan the further procedure. So I think, sir, it is already 8:45. I think we should start with that.
And when the PS, yes, but nicely done. When they ask them when they will recheck the PSA after removal of the catheter, or how, I mean, after how many weeks or so you will recheck the PSA.
Sir, he said about after 6 weeks.
Okay.
Ajay, why after 6 weeks? Why not after 2 weeks?
Sir, as there was a UTI and urosepsis, sir, the prostate, in case of any urinary tract infection, we should wait for 6 weeks for inflammation to be settled and PSA to come to the baseline. Sir.
No, that is not the answer. That is not the answer. If you have done a PSA at a wrong time, why do you wait for 6 weeks? Anik, why do you wait for 6 weeks? If he still does not have an infection, and if you have done acute retention of urine passing a catheter, why do you want to wait for 6 weeks, Anik?
Sir, prostatic inflammation had to be settled down.
No, there is no inflammation. Patient is having no fever, no tenderness on the prostate. The patient just comes, walks
Sir, the
in.
half-life of PSA.
And the serum PSA
Yeah,
half-life.
that is the answer. That is the answer, and not the inflammation and fever and other things. If the patient is still having prostatitis, you can still wait longer. But if you repeat a PSA, you have to see the trend of the PSA. If the trend has come down, then you have to wait. If the trend shows that it is on the higher side, then you have to take it with a pinch of salt, whether you have done it at the right time or not. So it is not the inflammation, it is a half-life. 3 half-life cycles have to go so that you can do a repeat a PSA 4 to 6 weeks minimum. You have to. Okay. So now we'll just talk about the prostate, open prostate steps, the steps of the surgery. There is an open simple prostatectomy. Have you ever seen? I don't know whether we should be teaching this to the children also or not now, to the candidates. This is a very controversial thing. All my seniors will be up my neck. But the thing is that open surgery, to me, I don't know what the other teachers have the opinion. Almost obsolete now. Nobody's doing it, and I don't feel. Anik, have you seen any open prostatectomy in your institute?
Yes, sir.
You have seen. Okay. Which is the one you have seen? You will take it with you, that
Sir,
only.
Sir, mostly retropubic procedure, Millings prostatectomy.
Prostatectomy is always, you have seen Millings.
Millings, sir.
Millings. How do you spell Millings?
MILLINS.
Okay, good. That is better. So now just tell us, enumerate the steps of Millings prostatectomy. What do you see?
Sir, position, the patient position will be supine, and a bolster will be given just below the pelvis, and it will be a
or bolster, or what can you do if you don't want to keep a bolster?
Sir, I can break the table.
Good. So reverse Trendelberg, you can give a Trendelberg
Reverse
position, sort of a,
sort of a,
and then
anesthesia. The anesthesia should be preferably under spinal anesthesia.
Okay.
After that, so incision. I will
you
start.
catheterize the patient, or you don't catheterize the patient. How is that you do it?
Yes, sir.
You take out the catheter, or you keep the catheter? You keep the catheter?
Yes, sir. I will catheterize the patient and put 30 ml NS in the balloon of the Foley's catheter.
Why 30 ml?
So that will help to identify the Foley's balloon easily when I will identify the neck of the bladder.
Okay. I slightly disagree on that, because you don't have to look at the bladder neck in Millings. In Freres, if you tell me, okay, fine, I'll still accept it, but not in Millings. Millings, so you don't feel for the bladder neck, no? Okay, then you give an incision. What sort of incision you make?
Sir, lower midline incision.
Lower midline incision. And the other incision preferred is?
Sir, Finan style incision.
Would you like to do a cystoscopy before doing a open prostatectomy?
Yes, sir. I will want to do
Why?
a cystoscopy.
Why? If the patient is on a catheter, why do you want to do an open cystoscopy? If the patient is already on a catheter, what information you want to get on a cystoscopy by doing a cystoscopy in such patients? What do you want to see? What is the aim of doing a cystoscopy?
Sir, to rule out any other pathology in the urinary bladder, such like sir, any very small urinary bladder SOL, or any urinary bladder calculus, or any urinary
calculus you cannot say, because you have done an ultrasound for the patient. They are high resolution ultrasounds, so I don't think calculus will be accepted. Other thing is I find this thing, okay, fine, small tumor maybe missed otherwise, so you can do it for that. Any other reason?
Sir, any urinary bladder diverticulum. Look for
that
any
you will
urinary
find on
bladder
ultrasound. How will that change any management? Even if there is a diverticulum, that will not change the management of the patient.
So in that
if
case,
patient is presented with hematuria.
Okay. Tumor, okay. Tumor I accept. I take your point, as tumor is one of the reasons. You want to rule out a tumor in such a patient, which again would be difficult with the larger medial lobes, but tumor is granted. Okay, now you have made an incision, so how do you go down?
Sir, I will cut through the anterior rectus sheath, will separate the rectus muscle, and will cut through the fossa transversalis. And after cutting fossa transversalis, I will enter into the space of the retgias, or in the anterior, just above the, just in the retropubic space. At that space, I will clear all the hypophatic tissue from the anterior wall of the prostate and the bladder, and will remove it to both on anterolateral aspect, and thus I shall expose bladder and the prostate. And after that, I will take control of the blood supply of the prostate, and for that reason I will have to cut the bilateral.
How do you do that? Control the blood supply?
Sir, I will take two figure of 8 stitches with large CTX needle with chromic catgut in 5 and 7 o'clock position of where the seminal vesicle encroaches bilaterally on the prostate, and that will take control of the prostatic blood supply. Then, and after that, I will cut the both lateral, the endopelvic fossa, and will dissect the puboprostatic ligament.
You will cut the endopelvic fascia and go to the puboprostatic ligament. Why?
Sir, to take control of the supply from the dorsal venous plexus.
No need.
I really doubt, Dr. Anjan. Is
No,
it the way
there is no need.
Millings is done?
You just
I thought
just
we are
clear
going
the
towards radical
fibrofatty
prostate.
tissue and see the capsule, glistening capsule of the prostate,
Exactly.
and you see the identify the prostatovesical junction, and then you make a curvilinear transverse incision over the
Or
anterior.
at the most you can take stay sutures.
Has sir.
But you,
Yes, sir,
don't
before-
go to, you never cut the
Probably-
endopelvic fascia and Millings. That is wrong.
Probably he's thinking of radical prostatectomy or what?
Yeah. I was thinking you can't, it is very deep. You just can't go there, and that if you go there, you're in a mess. I am really sorry, Anik. This is not the steps of Millings. This is wrong. Anything you want to add to this? Jay?
Sir, after that, I will take controls on the glistening prostatic capsule and the two line and both distally and proximally, and will cut.
Okay.
And we'll cut in between the two controls.
No, where do you take this stitch? What is the importance of taking these stay sutures? There are two things which these stay sutures do. One is hemostasis, you said, and second?
And second, sir, during dissection, the cut margins will not extend laterally.
Laterally, but they will not go recede also. You should, that is why what Dr. Anjan Das said is absolutely right. You have to be close to the bladder neck and not on the bladder neck. That is the most important step. Because if you are on the bladder neck, you develop post-operative bladder neck stenosis. And if you are far, just below, lot of tissue below the bladder neck, then you go very deep. And once the prostate goes off, it becomes very difficult to close the capsule.
Yes.
Okay, then what do you do?
After cutting the anterior capsule, and I will develop a plane between the prostatic adenoma and the capsule. And with the help of Medschanem scissors, the plane can be developed. And after cutting the anterior commissure and developing the plane, I will introduce my finger and will extend the plane bilaterally.
Initially, then you put a finger and take out the prostate preferably as a whole, or otherwise.
As a whole.
Can you look into the screen? You're not looking into the screen. Look into the screen. You're looking down. Yeah,
Yes, sir.
look this way. Now you have done this thing. The prostate is out. Now what do you do? There was a big median lobe also there. Now what are the important things you do? Where is the blood vessel? From where do you take the stitches?
Sir, the blood vessels will be. I will look for the prostatic fossa and will pack the prostatic fossa. And we'll wait for 2 minutes, and after that I shall remove. And after that I shall remove the pack, and we'll see if there is any bleeding. If there is any bleeding, then I will take 2 figure of 8 stitches at 5 o'clock and 7 o'clock position. That will control the prostatic vessels.
Medical. Either at 3 and 9 or 5 or 7. You have to take either of these. What is the step of retrigonation of the prostatic fossa? What do you do in that?
Sir, for the retrigonization, I will like to preferably first identify the 2 VUJ and will cannulate the 2 VUJ. And after that, I will put the bladder mucosa in the prostatic fossa and will cover the prostatic fossa with the help of the bladder mucosa.
And if it's a long mucosa, you have to take a wedge out of that. There is a neck is formed. You take a wedge out of that. Put an Alice over the mucosa and the prostatic mucosa and suture it over and over. Otherwise, it will bleed from there also. And how do you put a catheter? What size catheter you want to put? Now?
Sir, I want Sir, I want to put a 22 French Foley's catheter.
Two-way or three-way?
Three-way. Three-way.
Three-way. And then you inflate the balloon where?
With sir, around 30 ml of NS.
How much ml you fill up? Good point. I remember that now. How much ml will you fill up? It's 160 grams prostate. You fill up 30 ml. If it is 100 gram, then how much? How do you calculate that? How much you have to fill up? Is it same for every? Only 30 ml? If it is a 200 grams prostate, you fill up 30 ml?
No, sir. Then it will be very
How do you
small.
calculate? How do you calculate, man?
Sir, I don't know.
Ajay, how do you calculate?
Based on the diameter of the bladder neck, we can select the how much volume we should inflate, so that when we apply traction or anything,
No, that is not the
should
answer,
not go
Ajay.
into prostatic fossa.
What? How many grams? 30 ml. Then after per gram, how much ml? Ray, people have done work for you. You have to read. You have to read that there is a formula for that. How much ml you put up after for this number of prostate gland, you put 30 ml, and then after as the grams go on increasing, like you said, 1 gram per minute resection. Somebody has done that. Similarly, 10 ml per gram loss, blood loss. Similarly for this, now I'll not give you answer for this. This you have to read. Okay, how do you calculate how much balloon you have to inflate? And you inflate the balloon, Anik, while you are closing the capsule, or you have closed the capsule? How do you inflate the balloon? What point of surgery you inflate that balloon?
Sir, after closing the anterior capsule.
After closing the anterior capsule, and then you keep the balloon where? In the prostatic fossa or the bladder neck?
No, sir, in the prostatic fossa.
Ajay, where do you keep the balloon? In the prostatic fossa or bladder neck?
In the bladder neck, we will.
In the bladder neck. See, Anik, what you have answered is wrong. You don't keep this thing into the prostatic fossa ever.
Bladder neck.
Bladder neck.
Bladder neck. Okay. Okay, fine. So just towards coming to the end of the day, sir, Dr. Anjan, can you unshare it? I will just take a very small, the last part of this thing, what I've been allocated to do, and that is talk about the complications about QRP or HOLEP or enucleation of the prostate. I'll just take you through some points from the examination point of view and from your life career point of view, what you have to do and what you don't have to do.
So Rahul, I'll stop sharing. I'll stop sharing.
Okay, sir.
Yes, I'll stop sharing.
I'll share now, sir. Okay, my slides are visible. My slides are visible now?
Yes.
Yes, sir, visible.
Okay, great. So now I'll do the things. Just give me a minute. Yeah. So TURP or HOLEP is a gold standard managing BEP and BO. In the coming days, it is going to be like that. There is no discussion about that. We have already discussed that. What I'm going to talk is what can go wrong. So if you're a surgeon, you are a beginner, so you should be more cautious than an experienced surgeon, because he can get away with things. He would have seen things, but you have not. So you be very sure what you want to do and what you don't want to do. So what I'm going to discuss in this session is to discuss what can happen and how to overcome it safely from the examination point of view also. So what can happen? When can it happen? It can happen when you're starting the surgery. You have just given a Otis cut, or you do a ventral metotomy, and you can have a torrential bleeding that time also. So, or it can happen in the middle of the procedure, or it can happen towards the end of the procedure. So when you go retrospectively, all of us learn. We do get complications even now also. So would this have been avoided? We should know that. And if not, what are the options available? What would we have done that particular moment of time to have come out safely? The bottom line is safety of the patient. Even if when you're giving an exam, you be very sure that you talk what is safe for the patient. So patient's attendant would be there outside, hospital is on you, CPA is on you, your reputation at stake, and your colleagues and your friends will be after your life. So there is an intraoperative and perioperative and post-operative complications. So this is a standard for all complications of all surgical complications. So if anybody is asking you in exam, what are the complications of a procedure? you should not jump and start answering. You should always categorize into 3 categories. That is what can happen intraoperative, what can happen preoperative, and post-operative, what can happen. Now bleeding. Bleeding we were discussing for 160 grams prostate. So the bleeding can either be a primary hemorrhage. So what is the probability? 0.4 to 7.1%. Or in an infected prostate, which is the granulation tissue is there. So it can bleed and bleed and bleed. So the probability is 0.4 to 7.1%. So what is a secondary hemorrhage? Secondary hemorrhage is defined as a bleeding between 48 hours to 30 days. Patient, you are very happy, you've done a great job. You send the patient home, but he is not happy. He comes back to you after 3 days or 5 days. He said he is bleeding so badly that his catheter is blocked. So he comes back and gets back to you, and then you see there is a secondary hemorrhage in the patient, and the incidence is 7 to 10 days. So just by discharging the patient safely does not mean you're off the hook. You should be aware of it. So as one of the candidates said, you monopolar or bipolar, it does not make much of a difference. And if somebody asks you this question, what is going to bleed more? So there is bipolar versus monopolar resection. There is no difference provided you have done the job nicely. Both are equally bad in terms of bleeding. If you look at this thing, clot retention rate, if you see, it is the same between the monopolar and the bipolar. There is no difference. If somebody asks you what is the post-operative complication probability of patient developing clot retention in the post-op period, it is around 5%. So you may not, require to do a clot evacuation, but clot retention can happen in about 5% of patients. So how do you control the primary hemorrhage? It is manageable. So if there is a bleeding point, you always be very gentle, come back slowly, look where the bleeding point is, tilt it, squeeze the vessel, coagulate it nicely, keep the things there itself, and it will stop. Sometimes there is a bouncy bleeding, that the bleeding is everywhere, here and there and everywhere. So you look from where the bleeding is coming. It may be ricochet bleeding, as you can see here. Bleeding point is coming here and you're looking here. You have to be very cautious and learn. What I would tell you is, as a student, you should learn to coagulate. At least 15-20 cases, you tell your senior or a boss once you're in third year that said, I will do the coagulation for you. So learn that. That is more important than resecting. Resection anybody can do, but coagulation you should master. So complex situation will come when you open up a major sinus. If you have not seen it, you will definitely see someday in your life. Now the important point is when to stop and what to do. So if there is a sinus bleed, you don't have to, if somebody is asking you a question that you have started to operate a patient of a TURP, you're doing a TURP and suddenly the sinus opens up. So what you should answer is that what would you do? You cannot coagulate a sinus. Be very sure about it. You just cannot coagulate a sinus. If there is a sinus, it's a venous bleeding. It will not stop. So what you have to do is you just have to stop the procedure, and you have to sometimes open up do a cystotomy. That is not an insult. And if the patient is bleeding badly, you pack the fossa nicely or put a Foley's catheter from below, tuck it up and give a good tight traction, and the balloon should be in the bladder neck and not at the prostatic fossa. So once the bleeding is stopped and the irrigation is clear, you keep one edge of the ribbon outside and you start slowly start taking out the ribbon over a period of, under antibiotic cover, under analgesia. His BP should be controlled within 36 to 48 hours. This has to come out. So rarely, what are the newer technologies for doing it is you have to selectively embolize the iliac vessels or even the prostatic arteries. It's very difficult in India. I don't know whether it is happening or not, but if it is available, the PAE, that is called as prostate artery embolism, has to be done. The second complication which you can come across is a perforation. You can have a perforation which is a threatened perforation. Threatened means you can just see the, the capsule is perforated, but just a tinge of fat is seen and you are not gone through and through. That is, one is a covered perforation. Second is a free perforation. You can freely, you can see that the fluid is very fast going into the retroperitoneal space. And secondly, you can have a subtrigonal perforation. So I'll just show you one of the perforations. This is the intraoperative perforation. This is a subtrigonal. Can you see that perforation? This is done by me only, not somebody else. This is my video only. This is subtrigonal perforation. And when you find a subtrigonal perforation, it is in a medial lobe. When you're doing a medial lobe, there can be these pieces can go there and you can find a subtrigonal perforation. Fortunately, this happened when it was towards the terminal part of the procedure. So you just preferably put a guide wire, put a Foley's catheter over a guide wire so that you are very sure that it has not gone into the subtrigonal area, and then you give a tuck to that. So this is a HOLAP. In a HOLAP, it can also perforate. See, it's not that you perforate only in this. See, a nice big perforation is there. So fortunately, if there is no bleeding, again, you just don't put a catheter blindly. Preferably just think what you're going to do. Put up a guide wire inside. Be sure that your catheter is inside the bladder and not inside the prostatic fossa. So that is one of the things. Post-operatively, sometimes you can miss a perforation. You are not very sure. If the patient complains of pain abdomen, once the effect of spinal anesthesia is gone, you just palpate the bladder. See what is happening. See here, I'm just palpating the bladder of the patient. He is slightly comfortable. He's not complaining much. So you can wait on such a patient. Abdomen is soft. But if that is not the case, if there is any localized tenderness or rigidity or guarding, you have to take up the patient back to the theater and intervene and do either put a retroperitoneal drain or you have to do an exploration and close the bladder. Look at this perforation. This accidentally the cautery got opened up and the bladder perforated. The loop was outside in a active this thing and the bladder got perforated. See this is full thickness through and through perforation. It is very important to know the cause. You can't do anything. It has happened. But the site of perforation is important and how do you manage it? So for the morcellation, this is a video I have taken from Malik sir. They are just doing a morcellation of the prostate. You can see it nicely happening and suddenly there is a bleeding and you can't see anything. So what has happened is it has perforated the bladder through and through and it is an intraperitoneal perforation. What you do, what I did was we explored the patient. This was being done by one of our residents. So we explored it. There was a bladder opening. We just closed it in 2 layers. Done. And what was done at AINU, again, they have just closed it and it is done. There is no, if the patient lives, there is a slight morbidity, but there is nothing else you can do in these cases. So delayed complications, the patients present with passing fluid per rectum. This is very rare and unfortunate. Patient should not be, this should not be happening. So how to proceed about this thing? So somebody can ask, what is the incidence of a rectourethral fistulas post TRP? The incidence is less than 0.25%. You should know these percentages. It is very rare, but can happen if you are in a faulty technique. So this is the ensue in such a patient. So you can see clearly the fluid is extravasating into the rectum and a CT urogram was also done. So you can see that fistula. This is a video in which it was cannulated to confirm. So the guide wire went into that and came out through the rectum in this case. So the patient was passing some fluid through the rectum. So now how do you treat such a patient? Somebody can, if you are performing well, only then you will reach up to this stage. So what was conservative treatment is one of the ways of treating such patients. Surgically, how can you do? You can do either open surgery. If you don't know how to do it, send it to an expert. Tell the patient this has happened. Take the help of your senior. You can do it transvesically, transperitoneal approach or perineal approach. You can do it robotically or laparoscopically, whatever you are good at. So this is the procedure which is being done. What was done in our case was conservatively, we put an SPC and kept him in a low residual diet, it healed itself, did a distal lupogram. We had done a colostomy on this patient and this healed very nicely. So rare complication is a penile burn. Sometimes the patient can come back after 3 weeks with this thing to you. This is because of a leak of the cautery and it can cause at the friction point. So you should use a lot of jelly or some people use Betnovit ointment and over the whole of the sheath and they are using it. You should look for the earthing of the table as well as the cautery machines. Get it regularly checked. This is unacceptable complication, but can happen and give you a bad name. So energy source should be seen. Where you have gone wrong, checklist to avoid avoidable unpleasant complication. You have done a good job prostate wise, but patient is still unhappy with you. So post-operative stricture is not rare to find if you are not using an adequate size of instrument. You have not dilated the patient normally. You have not used the otis. So these are very small things. If you are using a good otis and dilating it well, so these complications are again avoidable complications. Look at this. You've done a very good job with the prostate, but the patient is having a very short stricture, and he's going to be he's going to be your patient forever, and he's not going to be happy. So this can happen because of oversize of the resectoscope, mechanical stress. You're doing 160 grams prostate. You want to do it a heroic job by doing a transurethral resection, and you have not lubricated it well. Your speed is not good. You've taken 3 hours to do it. Bound to happen develop a stricture. So you can avoid that by doing a simple open millins or sending it to an expert resectionist who can take less time and do a better job on you. So the current leaks can cause stenosis. So there is there a difference in return of a monopolar and a bipolar? Yes, it is definitely there. But if there is a short circuit in the elective electrode, you can still get these mucosal burns and you can get the strictures, which is, again, I'm telling you, it's a very unpleasant situation. So if in the examination somebody asks you, hey, what is the cause of poor flow in the post-operative period? One of the cause is a stricture in the urethra. So bladder neck stenosis, the incidence you should know, it is less than 10% after transurethral resection, and after holmium and thulmium laser enucleation, it is slightly less. The reason being that you get a big fossa there, so you don't get it. The predisposing factors are a smaller prostate, excessive cauterization you have done for hemostasis. As a beginner, you want to patient not to bleed, so you tend to do excessive cauterization, and you can get a bladder neck stenosis. Again, it is a avoidable complications. So you should remember this chart for a prostate surgery. Overall complication rates are 3% with the improving cautery and everything. Hemorrhage 2 to 10%. Urethral injury less than 5%. Bladder injuries is rare. TUR syndromes, though it is mentioned 1 to 7%, but in present era we hardly see any. And the other unpleasant and mortality is definitely very, very low. So this is one of the last slides. Almost 57 studies were included in this retrospective analysis of a systematic review of the complications of holmium enucleation. And if you see, the complication rates are almost the same as good as what you do for TURP. So bladder perforations, hematuria, clot retention is again there with this. So no one procedure is a safe procedure until you do it safely. So complications can happen to those who operate. Don't panic. Always take help. There is no ego in that, and learn from them, and don't repeat the same, which is unacceptable. Thank you. Thank you very much. Any questions from the candidates? We have asked you questions. If you want to ask any questions, you are most welcome. Okay. If you don't have any questions, then I think it is the time to say thank you to everyone who have participated. Thank you. I hope they have learned something from today's this thing. But again, I'll hand it over to Ranjan sir for the final comments and take home message. Thank you very much. Thank you for having me.
I can only say thank you to all the teachers. They have really performed out of much more than we are expecting for our students. You have time, you have given, and the depth, the way you have questioned them, and the answer has been provided by all of you. I am really thankful to all my teachers, to those that really cooperated today to make it a very successful event. From the students also to face the question, they must prepare. They must prepare for this event, because teachers have taken so much of effort. More sensible answers should come from a student. It is expected from all of you. But with this, I must thank Dr. Samir Swine, Dr. Professor Anjan Das, and Dr. Rahul for excellent session they have got today with your help only. And we'll be meeting tomorrow once again for the andrology session. Good night. Thank you very much. Rahul, I hope I have done a sensible.
No, sir. I think once that thing comes up, this will be a great help to the residents, and I think they should put more. Yeah. I agree with you. They should put more effort, because this way it is very difficult, because they should read the basic reading is very important. You will find all the answers in the books, but now maybe the generation is changing, things are changing, but they should know the percentages at their level. At least they have no excuse not to know what is what is rarity, what percentage probability.
Yeah, definitely. Yesterday we all, Samir, myself and others, they all have come back from the national mock test. We faced the same scenario there. Same scenario. Basic questions are not answered by the students. That's a very painful thing, because day to day they will have to face the basic problems only, not the very high rated complications they will face. Okay, thank you. Rahul, thank you, Dr. Kundu, Anjanda, and everybody for this nice evening. We hope we'll continue with this tomorrow evening. Thank you.
Thank you. Thank you.
Good night to everyone.
Thank you.
Good night.
Yeah. Thank you, sir. Thank you.
Good night, sir.
Good night.
Good night.